Good evening, everyone. I thank Receptor team for inviting me and chairpersons for your kind words of introduction. So my topic is going to be on hidden hormones and how to unmask endocrine hypertension. So the prevalence of hypertension itself is 40% in the whole world population, of which essential hypertension is about 85%, and some studies quote up to 30% of the hypertension is due to secondary hypertension. Children presenting with hypertension could have up to 50% could have secondary cause as the cause of hypertension. In young adults less than 40 years old, 30% could have secondary hypertension. So when do you suspect that someone could have secondary hypertension? Patients with early onset hypertension less than 30 years of age, in the absence of hypertension risk factors, those with resistant hypertension, those are needing more than 3 antihypertensives, of which one is a good dose of a diuretic. When there is a sudden deterioration in a very well controlled hypertension, hypertensive emergencies, and there's a strong clinical clue that this is not an essential hypertension and there could be something else going on in this patient, then we should start looking for other causes, which is secondary cause of hypertension. So when we talk about the adrenal causes as a cause of secondary hypertension, the most common is the primary hyperaldosteronism. Second would be the Cushing's, followed by the pheochromocytoma. I will talk more about cons, which is endocrine condition that we often overlook or don't look for at all. Cushing's will be covered by the next speaker, and I'll be presenting cases to describe better the scenarios. There are some less common conditions that cause hyperdeoxycorticosteronism, such as the virilizing form of congenital adrenal hyperplasia due to 11-beta hydroxylase and 17-alpha hydroxylase deficiency, the DOCA-producing tumors, and the rare primary glucocorticoid resistance causing Crouzos syndrome, the syndrome of apparent mineralocorticoid excess because of the 11-beta hydroxysteroid dehydrogenase 2 deficiency. These are rare, but just need to remember that there are rare syndromes do exist. So why do we get hypertension when there is a problem in the adrenal gland? It could be high renin, high aldosterone producing condition. It could be a low renin, low aldosterone producing condition. And there is a high aldo, low renin producing conditions such as the cons. When you look into the adrenal medulla, there's only one condition that causes it, which is the catecholamine elevation because of pheochromocytoma. We very well know that renin is produced by the kidney when it responds to low blood pressure and low salt, and this converts the angiotensinogen that's produced by the liver into angiotensin 1. The angiotensin 1 gets converted to angiotensin 2 by the angiotensin converting enzyme, which is produced solely by the lungs. So this angiotensin 2 is a potent vasoconstrictor, and this stimulates the adrenal cortex to produce aldosterone, which works on the kidneys and results in reabsorption of sodium and water. So this is the basic underlying physiology. Let me go through the case to make you understand a bit better. So let us look into this 28-year-old male who presents with resistant hypertension despite treatment with 3 antihypertensives, amlodipine, telmisartan, and hydrochlorothiazide. His blood pressure remains elevated at 160 by 100. His symptoms reports occasional muscle cramps, fatigue, but no other symptoms. These are his lab values: a potassium of 3, sodium of 142, aldosterone which is elevated, 35 nanograms per deciliter. Anything more than 10 is significant. Plasma renin activity is 0.2, anything less than 1 is significant. And aldosterone renin ratio will be referred to as ARR henceforth. Anything more than 20 is significant, and this patient has got 175. So this is typical of primary hyperaldosteronism. So this image, a non-contrast CT adrenal, shows a 12 millimeter hypodense nodule in the left adrenal with normal right adrenal and no other abnormalities. So the diagnosis is primary hyperaldosteronism. So, but seldom it is this straightforward. We don't get values that meet the criteria for Conn syndrome, and often the renin-aldosterone values are quite vague or indeterminate. So, the primary aldosteronism, we think is the adenoma that's common, but it's bilateral idiopathic hyperplasia that contributes to 60% of cause of primary aldosteronism, and the adenoma contributes to 35%. There are other less common, rarer conditions: the unilateral adrenal hyperplasia, adrenocortical carcinoma, familial hyperaldosteronism. There are at least 4 different types which are caused by genetic mutations, ectopic aldosterone adenoma or carcinoma. As you can see, they're very, very rare. So this is the guidelines suggested by the Endocrine Society, published just last year, 2025. And what they suggest is the sample should be done when the patient is upright, should be mobilized for at least 2 hours, and then the patient sit for at least 5 to 15 minutes, and then you do the plasma renin activity and aldosterone. I apologize, this highlighted one is not seen properly, but the plasma renin activity should be less than 1 nanogram per ml per hour, and the aldosterone absolute level should be more than 10 nanograms per deciliter when done by an immunoassay, and the ARR ratio should be more than 20. So less than 10 of renin, suppressed renin, more than 10 of aldosterone, and ARR ratio of more than 20. But the problem is these cutoffs are all not actually fixed cutoffs. It depends upon the assay, your local laboratory, how good they are, and so forth. And there are several drugs that can interfere as well. Let's look into these scenarios where there are different aldosterone, renin activity, and ARR ratios. So first case where the aldosterone is 6 and the plasma renin activity is 3.2, the ARR is 2 with normokalemia, and this is low ARR. As I said, the ARR should be more than 20. So this is low ARR, and so it is not primary hyperaldosteronism, and so we don't have to proceed further. The second case where the aldosterone is 3 but the plasma renin activity is low, the ARR is 30 and the potassium is normal, but as you can see, the aldosterone is very low, and despite the ARR ratio being high, this is probably not hyperaldosteronism. The third scenario where the aldosterone is 18 and the plasma renin activity is 0.6 and the ARR is 30 is a positive screen, and you should go for confirmatory testing. The fourth case where the aldosterone is 11 and the plasma renin activity is 0.8, the ARR is 15, is probably primary aldosteronism, but the potassium is low. Remember to correct the potassium by supplementing it and making the patient normokalemic before you do a plasma renin activity or aldosterone levels, otherwise the results may not be accurate. So you'll have to supplement and rescreen in this scenario. The last case scenario is where the aldosterone is 38 and the plasma renin activity is 2 and the ARR is 19. It's probably primary aldosteronism, but remember the plasma renin should be suppressed, but in this case not suppressed, so probably some confounding drugs, look out for them, and you could probably proceed in this patient to confirmatory test or stop the offending drugs and reassess. So these are the different drugs that can interfere with the renin and aldosterone levels. I'm not going to go into the details, but the guidelines suggest you don't have to stop these as long as you know how to interpret the renin and aldosterone values when the patient is already on these medications. So most drugs increase the plasma renin activity and aldosterone, but the beta blockers reduce the plasma renin activity. So you should be aware when the patient is on antihypertensives if you want to stop and if it is safe to stop, or you can continue these and then interpret the renin aldosterone ratio and the values in the context of the drugs. So up to 4 weeks you may have to stop spironolactone and eplerenone, but if it's still okay if you're able to interpret it, if the plasma renin activity is suppressed, you can still go ahead and continue and interpret. The best combination to use will be an alpha blocker and verapamil. And you can always rescreen after stopping the drugs, but in an Indian scenario where cost is a major factor and none of these tests are covered by insurance, you cannot keep on reassessing. So you should be able to assess, interpret, and the context of continuing the drugs, or send to a specialist who will be able to do that, or stop and do the test to begin with if you think it is safe to do so. If it is straightforward where the renin activity is suppressed and the aldosterone is high, there is no need to do confirmatory tests. But in certain situations, you'll have to do either an oral salt loading or saline suppression or captopril challenge test to confirm if it is primary hyperaldosteronism. Treatment would depend upon if it's a bilateral disease, if the patient is willing for surgery, which is the definitive treatment. So if it's a bilateral disease, or if there is normal CT despite a confirmatory test, or the patient is unwilling or unfit for surgery, then gives spironolactone and eplerenone. But it is better to make an underdiagnosis so that if then the patient goes away from your OP, nobody else stops these mineralocorticoid receptor agonists, because then the patient will develop resistant hypertension. Adrenal vein sampling in selected cases where the probability of lateralization is high, then you go ahead with adrenalectomy. So adrenal vein sampling is a bit tricky. The success rate even in very good centers is 70 to 95%. It is not needed in clear-cut cases where the patient's age is less than 35, there is a unilateral adenoma, high ARR and hypokalemia. You don't have to do adrenal vein sampling. You can just counsel and go straight away to adrenalectomy. Let me look into the second case. 55-year-old female presents to master health checkup with a blood pressure of 160 by 100 with no significant past medical history or drug history. Ultrasound shows a 5 centimeter cystic lesion near the kidney. CT abdomen shows a cystic 5.5 centimeter adrenal lesion. So what do you think this condition is? So the plasma-free metanephrine is elevated, plasma-free normetanephrine is elevated as well. So we went ahead and did a gallium DOTA. Unfortunately, I don't have the images. It shows a moderate uptake in the peripherally enhancing with a central hypodense adrenal lesion. There's no enhancement elsewhere to suggest metastasis. So this is a cystic pheochromocytoma. Any cystic adrenal lesion, you'll have to consider cystic pheochromocytoma and rule it out. They may not present with all the symptoms, but remember these 5 Ps. They can have sustained hypertension, which occasional spikes. Throbbing headache is one of the very common symptoms. They can present with chest pain. Perspiration could be heavy and generalized, palpitation and pallor. Remember, the 6th P is that none of these symptoms can be need to be present all the time. These can be paroxysmal symptoms. So other findings are hyperglycemia, weight loss, tremor, orthostasis, hypercalcemia, fatty liver, cardiomyopathy. But 10% of the patients can be asymptomatic, like my patient who present to master health checkup. What test to do? See, remember there are drugs and coffee, fruits and beverages that can interfere with these assays. So you need to pick an assay after you have asked the patient to stop some of these interfering food and drugs for at least 72 hours. I usually do a plasma metanephrine and normetanephrine, which has got very good sensitivity of 99% and it's 89% specific. You can also do urinary metanephrines or urinary catecholamines, which is it's got less sensitivity and specificity. But you need to remember that it's just pheochromocytoma is just one entity. There are other syndromes that can be associated with pheochromocytoma, depending upon if it is bilateral, if there is hypercalcemia, if there's a family history. So those things should be borne in mind when you're ordering these investigations. Usually pheochromocytomas are big tumors. If the patient is really symptomatic, the tumor should be visible somewhere. Occult tumors do not cause symptoms. As I said, there are several diseases and genes associated with pheochromocytoma. We should leave it to the specialist to investigate this further. CT scan is good enough. It's obvious, high resolution scans. Symptomatic fears are not small. MRI is usually not necessary. MIBG scan is not usually necessary. And I usually get on to do with a gallium DOTA scan if you have it in your center. Useful to look for metastasis. Management, adrenectomy is the treatment of choice. Alpha block for at least 7 days prior to surgery. The blood pressure should be in a state where the patient feels dizzy. Even if it's 90-60, that will do. I usually give an alpha block, then beta block at least for 2 days pre-surgery. High sodium diet, 5 grams per day, and generous fluid intake. I usually admit the patients 2 days before surgery, give IV fluids because we cannot always trust our patients how much fluids they have taken. Give IV fluids. You need an experienced surgeon and a lot more, an experienced anesthetist who will be able to manage the blood pressure spike when the surgery is being done. The blood pressure can go up to 300 and cause a lot of panic, so you need an experienced surgeon and an anesthetist. This patient had pheochromocytoma and ganglioneuroma. Again, ganglioneuromas are usually non-functional, but they can produce metanephrines and norepinephrines. So those are the two common scenarios, common cases, but I'll go on to more uncommon cases just for you to be aware of that these cases do exist and might come your way. So 7-year-old male, normal delivery, normal milestones, no significant past medical history, referred with precocious puberty. He is found to be hypokalemic and his blood pressure is 150/90, and his bone age, which we usually do for someone who presents with short stature, delayed puberty or precocious puberty, we do the bone age, and he is quite mature. The bone age is quite mature for his age, 7 years. So this is typical of 11-beta hydroxylase deficiency, which is very uncommon. So this is the pathway of steroid production, where from the cortisol, pregnenolone gets converted to progesterone to 11-deoxycorticosterone. The 11-deoxycorticosterone gets converted to corticosterone. So this is the place where the 11-beta hydroxylase acts, and when this is deficient, the 11-deoxycorticosterone is elevated. There is cortisol deficiency, and the pathway is shifted to androgen production, where there is increase in testosterone that causes precocious puberty. So 2/3 of these patients with this classic form of 11-beta hydroxylase present with hypertension, beginning within the first few days, years of life. They can also present with left ventricular hypertrophy or even retinopathy. In up to 1/3 of patients, there are reports of stroke and death because of cerebrovascular accidents. They usually present with hypokalemia, muscle weakness, or cramps, but this does not well correlate with blood pressure. The plasma renin activity is low and the aldosterone is low. So it causes low aldosterone, low renin, hypertension. Both the sexes are present with hypertension, low potassium, precocious puberty, accelerated skeletal maturity, and short stature. In girls, they can present with ambiguous genitalia because of excess androgens, but they do have intact reproductive tract. They have premature adrenarche, acne, amenorrhea, or oligomenorrhea. In boys, they present with precocious puberty and poor spermatogenesis. There is no consistent correlation between the severity of hypertension and the degree of virilization. The management is glucocorticoids and potassium-sparing diuretics. Do not give ACE or ARBs or thiazides because they do not work in this group. There's another condition called 17-alpha hydroxylase, where this pregnenolone and progesterone is not converted to 17-hydroxypregnenolone or progesterone. So it's the opposite. So you still have excess 11-deoxycorticosterone, but less of the androgens because of 17-alpha hydroxylase deficiency, and they usually present, the females present with normal external genitalia, but primary amenorrhea. Males are often considered as female and they're grown as, they're brought up as females or with ambiguous external genitalia until they present with hypertension and hypokalemia, and then they undergo karyotyping which shows male karyotype. So Liddle syndrome, autosomal dominant condition, there's abnormality in cytoplasmic domain of beta and gamma subunit of epithelial sodium channel. So they present with again metabolic alkalosis and hypokalemia. And the treatment is mineralocorticoid antagonist spironolactone or ineffective, but the treatment is amiloride and triamterene. So that is something to remember in Liddle syndrome. The extraordinary causes are paragangliomas, hyperparathyroidism, acromegaly, Cushing's disease, and renovascular hypertension, and sometimes hypo and hyperthyroidism because of changes in the blood volume, systemic vascular resistance, changes in the renin-angiotensin system, increase in cardiac output and hyperthyroidism, and decrease in the activation of renin-angiotensin system activation, leading to increase in diastolic hypertension and hypothyroidism. But in hyperthyroidism, you see increase in systolic blood pressure. Hyperparathyroidism, 40% can have hypertension. The mechanism is unclear, could be due to arterial stiffness. This could improve after surgery unless you were not treated the hyperparathyroidism long term. Acromegaly can also present as hypertension in 50% of the cases because of excess sodium and water retention, blood volume expansion. So when should you refer? At primary care, you should have high index of suspicion when all these clinical criteria is met. You can do baseline investigations, but please do refer to the secondary care for further investigations to look for Cons or Cushing's or to look for acromegaly. But tertiary care is the ones who should investigate where there is access for the adrenal vein sampling, DOTA scan, and inferior petrosal sinus sampling or genetic testing. So take-home message is secondary hypertension due to endocrine causes are common but often not thought of. In all individuals with hypertension, this is the latest guideline. It is suggested screening for primary hyperaldosteronism, where the morbidity, mortality is more and it is independent of high blood pressure. Clinical suspicion, screen appropriate cases, timely referral to specialists can avoid unnecessary investigations and prevent complications. Thank you very much.